Good evening, Professor Mee-Lee.
Happy
Welcome.
to be here.
Thank you.
Yes.
Welcome to Singapore.
Thank you.
I hope the conference was an experience for you, and as much as it was for all of us, I think it was a
Yeah.
fantastic day today.
Yes, I enjoyed it as well.
Excellent. I just have a few questions. It was very interesting to hear you speak today. And I think the first question that comes to mind is, in our region, in the Southeast Asia region, we employ the biopsychosocial model as well, but it is pretty much based on Western science
Yeah.
and Western psychiatry.
Yeah.
Do you think that we are able to culturalize it to the local context, or do we need to do more? What are your thoughts, sir?
Yeah. Well, I think the beauty and the importance of the biopsychosocial model is that you're looking at the whole person. And the whole person means not just looking at that individual patient or client, but in the context of their family and the community and the society and the culture of the community. So it's good that you're using a biopsychosocial model, but for each area, we really have to understand what are some of the unique aspects of family life, of the values of the culture, of the norms in this society, and
Right.
that's where it's important to see, are we actually adapting that to this particular individual's unique view of the family and the culture and the values.
Right. We see quite in a population from various countries around the world as clients and patients. And sometimes, personally for me as a clinician also, I find it a little bit of a struggle working with different cultures and trying to use the same therapeutic model or therapeutic approach. It can be a struggle sometimes.
Yeah, and I guess that's the meaning of cultural competence and of cultural sensitivity. But even in a very uniform culture, we still have to take an individualized approach, because
Right.
even within, say, the Western culture, families are different, values are different, people's personal culture. So we have to do that anyway, but then there's an added importance to make sure it matches in areas like this to
Right.
people's very real differences in culture.
Right. And I think now, even in Singapore or Malaysia, there's this concept of acculturation that's happening as well, where different cultures come here and then they merge with a different culture, and then the kids have a different concept.
That's right.
So it's very interesting, very interesting.
Yeah. So what you're saying is that even within a culture, there may
Yep.
be different cultures between generations.
Exactly.
And different
Exactly.
outlooks. Yeah.
Yeah, even between the parents and the
That's
children,
right.
and
Yeah.
it varies.
Yeah.
You can see the difference a lot.
I think I think if we always think of each person as an individual within their
Right.
context, then that helps to make sure we design services that meets that particular person's needs.
Right.
So it's like they have their own culture, within a family culture too.
Right. Right.
Yeah.
Okay.
Not to overcomplicate it, but to make sure that we're being not one size fits all,
Yes, of course. Yes, I think we have learned that here over the years.
Yes.
One size doesn't fit all. And that brings me to my second question. This is in regards to actually your talk today, which was about recovery, and
Yes.
it got many of us very interested, because the concept of recovery and the concept of abstinence
Yes.
seems to have a lot of difference, and we seem to use these words interchangeably
Yes.
without understanding the definition and the context.
That's right.
Could you comment on that, please, Prof. Mee-Lee?
Yes, I think that we have often used recovery in a sort of general way to mean people, stop drinking or drugging.
Yes.
But it's really, if you think of recovery in its fullest sense, abstinence and not using is just necessary but not sufficient to determine a recovery mentality. And
Right.
it actually gets tricky when you think about medications in addiction treatment, because
Okay.
some people would see anybody who's on medication as not being in recovery.
Right.
And yet, you can make a case for being on medication doesn't mean you're not in recovery if you're using that medication in a prescribed way for treatment of addiction. That recovery is more about growing physically, mentally, spiritually, socially,
Right.
not just not using. Because you can have, like in AA, dry drunk. Somebody could be not using, but they
Yeah.
haven't growing.
Yeah.
They're not in recovery. They're
Yeah.
dry but not sober. They're sober but not in full recovery. So I
Right.
think making a distinction between abstinence and full, growth is important to
Right.
look at recovery and wellness.
Right. I think here in our region, maybe in this, I keep referring to our region as Southeast Asia region, this concept of recovery is still a little bit of a struggle for many of us here, even professionals. You mentioned medical assisted therapy, MAT, which I found very fascinating, because it's true. Why do we have to say addiction is, I like the way you explained it.
Yeah.
When we don't have diabetic assisted therapy,
Yeah.
but we have addiction medical
Yeah.
assisted therapy.
Yeah, I mean, we don't say, as you say, medication-assisted diabetes treatment,
That's right.
medication-assisted hypertension treatment, because it makes medication sort of second class or something.
Right.
And we're not trying to make it first class, we're just saying it's one tool in a clinical array of things, which if some people need it, they should get it, but if they don't need it, they shouldn't get
They
it.
shouldn't get
But sometimes people think of it as a philosophy. We don't
Right.
believe in medication.
Right.
Yeah.
Right.
Yeah.
Okay, thank you. I think another question that I would like to ask you, sir, is in regarding to continuum care. Now, the concept of some people tend to think if I go to treatment, I stay in rehab or I stay in hospital, I'm out, I'm done.
Yeah.
I paid my dues.
Yeah.
And it's time for me to move on in life.
Yeah.
What are your thoughts about continuum care? Because
Yeah.
there's a lot of
Well,
gray area about it.
I mean, if you believe addiction is a potentially chronic illness that can flare up, we have to treat it with the same principles that we do with other ongoing illnesses like hypertension, diabetes, depression, schizophrenia. We want to see treatment as, if somebody comes to residential treatment, that's a piece of a treatment continuum, but
Right.
it's not cured and it's not graduated and completed. So
Yes.
we want to start watching our language to have, even when we say aftercare, we don't say what's aftercare for diabetes treatment, what's aftercare for depression treatment. It's just treatment, and some people, most people I would say, need to have some sort of continuing care to monitor their progress in this chronic illness because it can flare up. We hope nobody ever has to flare up again, but it's very common to have flare-ups
It
in
is.
use. So
It is.
if we're not monitoring that, that would be the same as not monitoring somebody's diabetes or
That's true.
hypertension or schizophrenia or whatever.
Okay.
So I think it's important to help clients and patients understand you're doing a piece of work, but this is just a sort of beginning of an ongoing process where we want to keep them coming back in a way, as we say in AA. So yeah,
Keep coming back.
yeah.
Okay. So, Professor Mee-Lee, one more question that I think that comes to mind now, with our conversation is,
Yeah.
what are your thoughts on dual diagnosis or comorbid disorders?
Yeah.
Because what happens sometimes is patients go to see a doctor or a psychiatrist and they present certain symptoms.
Yeah.
And the doctors tend to, diagnose them with schizophrenia or bipolar based on the symptoms.
Yes.
And then they're medicated accordingly.
Yes.
And sometimes the addiction is not attended to. What are your
Yes.
thoughts on this, Prof?
Yeah, one of the problems is that people who are trained in mental health and psychiatry are often not well trained in addiction
Right.
treatment, and vice versa. People who are trained in addiction not well trained in mental health issues.
Right.
So whenever we do an assessment of somebody who's drinking and drugging and has mental health signs and symptoms, we want to try to make sure it's an assessment done by somebody who has experience and understanding of both
Right.
sides of the fence, so that they can distinguish, is this person's looks like they have a psychiatric disorder,
Right.
but this is really just a manifestation of addiction, whatever they're using, uppers
Right.
and downers, having mood swings.
Right.
And in the same way, people in addiction treatment need to make sure they don't just say, well, this person's got depression, but that's just because they are going through withdrawal, and then not take careful assessment of, well, maybe they have co-occurring trauma that is causing problems. So there are some principles to assess and distinguish between, is this addiction, is it mental health, is it a co-occurring dual diagnosis?
Okay. Now, what are your thoughts about, sometimes what we see is the patient goes and sees the doctor or the medical practitioner
Yeah.
for a sitting of maybe half an hour and he comes back with a diagnosis. What are your thoughts on this, Prof?
Well, if we don't have confidence that the doctor understands addiction and takes a substance history and looks at the relationship between mental health, signs and symptoms, and using, for example, if somebody has what appears to be mood swings, but they're using uppers and downers, then that's not a good evaluation just to name the signs and symptoms as a psychiatric diagnosis. Or if somebody has depression but they're crashing from cocaine, if you have a mental health evaluation by somebody who doesn't understand those different manifestations, then they're going to come up with some psychiatric diagnosis.
Right.
But we want to make sure it's somebody who understands, were you using at the time that you had the mental health problems? Did the mental health problems occur before you had addiction problems? Did it happen when you weren't using? All these sorts of questions are important in a good assessment to determine, is it truly a co-occurring problem?
Okay.
Yeah.
So the evaluations and assessments have to be done in a very formatted, structured, and in a thorough way before we can come up with an actual diagnosis.
And with an understanding of how addiction can mimic and look like psychiatric problems. And, which
happens quite often, I think.
Yes.
Some of the symptoms, the manifestation of the symptoms. Okay.
Yeah.
All right. Thank you, Prof. Mee-Lee. That was very, very educational and very helpful. Thank you very much, sir.
Thank you.